Good morning, students. Today's lecture topic is rheumatoid arthritis. Let's move to the introduction part first. Rheumatoid arthritis is the most common cause of chronic inflammatory joint disease. Most typical features of it are asymmetrical polyarthritis and tenosynovitis. What is polyarthritis? Polyarthritis refers to a joint disease that involves at least 5 joints. One or more signs of inflammation, including pain, movement restrictions, swelling, warmth, and redness, are seen in the joints involved. Next comes the tenosynovitis. It is the inflammation of the tendon sheath where muscle connects to the bone. Tenosynovitis is a painful condition. The hands, wrists, and feet are often affected in this condition. The most common cause of tenosynovitis are injury, repetitive use, and infection. Next comes the morning stiffness. Now, what is morning stiffness? Morning stiffness is generally the slowness or difficulty in moving the joints when getting out of bed or after staying in one position for too long, which involves both sides of the body and gets better with the movement. Elevation of the erythrocyte sedimentation rate, appearance of autoantibodies that targets immunoglobulins in the serum. Now here comes the term autoantibodies. Now what are autoantibodies? I'll let you know. Autoantibodies are an antibody made against substances formed by a person's own body. Autoantibodies can directly destroy cells that have the substances on them or can make it easier for other white blood cells to destroy them. Some autoimmune diseases are caused by autoantibodies. It is a systemic autoimmune disease and changes can be widespread in a number of tissues of the body. Rheumatoid arthritis tend to die younger than their peers as a result of the effects of chronic inflammation on a number of organ systems. Next is chief among this is early ischemic heart disease secondary to the effects of inflammation on the cardiovascular system. Now, in this point comes the term ischemic heart disease. What is ischemic heart disease? It is the damage or disease in the heart's major blood vessel. The usual cause is the buildup of plaque. This causes coronary artery to narrow, limiting the blood flow of the heart. Now, here comes the question, what is the main cause of ischemic heart disease? I'll let you know that what is the cause of ischemic heart disease. Atherosclerosis is the most common cause of myocardial ischemia, that is blood clot. The plaques that develop in atherosclerosis can rupture, causing a blood clot. The clot might block an artery and lead to sudden severe myocardial ischemia, which is resulting in a heart attack. Moving forward. But here comes the one more term, that is cardiovascular system. Just because it is affecting it. So we'll have a look at this term also. Cardiovascular system is also known as the circulatory system generally, which pumps the blood from the heart to the lungs to get the oxygen. The heart then sends oxygenated blood through the arteries to the rest of the body. The veins carry oxygen, pour blood back to the heart to start the circulation process over. Moving forward to the next slide, epidemiology. It affects 1 to 3% of the population worldwide, with a peak prevalence between the ages of 30 and 50 years. And here, women are affected 3 or 4 times more commonly than the males. Moving forward to the next slide. Now let's have a look at the causes. The first cause of RA, that is rheumatoid arthritis, is genetic susceptibility. Now, what is genetic susceptibility? It is an increased chance of likelihood of developing a particular disease based on the presence of one or more genetic variants, or a family history suggestive of an increased risk of the disease. An immunological reaction possible involving a foreign antigens. Here comes the word foreign antigen. What are foreign antigens? I'll let you know. Foreign antigens originate from outside of the body. For example, include parts of or substances produced by viruses or microorganisms such as bacteria and protozoa, as well as substances in snakes, venom, certain protein in the food, and component of serum and RBC red blood cells from other individuals. Next point, an inflammatory reaction in joint and tendon sheath. The appearance of rheumatoid factor in the blood and synovium. Perpetuation of an inflammatory processes, articular cartilage destruction. Now here comes the word articular cartilage destruction. Now what is articular cartilage destruction? Let's have a look at this term. Destruction and loss of articular cartilage is a central feature in most forms of arthritis, including the most common form of osteoarthritis. The pathobiologic difference among the various types of arthritis relates, at least in part, to differences in mechanism driving cartilage destructions. Let's move forward on the next slide. Here is the pathology of rheumatoid arthritis. As you can see in the picture, rheumatoid arthritis is a systemic disease, but the most common characteristic lesions are seen in the synovium or within rheumatoid nodules. The synovium is engorged with new blood vessels and packed full of inflammatory cells. Next point, before rheumatoid arthritis, because clinically apparent the immune pathology is already beginning. Here we can see the raised ESR. ESR stands for erythrocyte sedimentation rate. An erythrocyte sedimentation rate measures how quickly the red blood cells settle in a test tube. It can help detect inflammation in the body as well. Also, C-reactive protein, that is CRP, and RF may be detectable years before the first diagnosis. Early changes are vascular congestion with new blood cells formation, proliferation of synoviocytes, infiltration of the subsynovial layers by polymorphs, lymphocytes, and plasma cells. There is a thickening of the capsular structures, villus formation of the synovium, and a cell-rich effusion onto the joints and tendon sheath. As you can see in the picture, here is stage 2 of synovial. The third stage is destruction. Persistent inflammation causes joint and tendon destructions. Articular cartilages is eroded. At the margins of the joint, bone is also eroded by granulation tissues invasion and osteoclastic resorption. As you can see in the picture A, B, C, and D. This is how at the margins of the joint, bone is also eroded by granulation tissue. Similar changes occurs in dentate sheets causing tenosynovitis as we have discussed earlier. Partial or complete rupture of tendons as you can see in the picture. Swelling of the joint tendons and bursa. Moving forward on the next slide, the stage 4 of rheumatoid arthritis is deformity. Combination of articular destruction, capsular stretching, and tendons rupture leads to progressive instability and deformity of the joint. The inflammatory process usually continues, but the mechanical and functional effects of joint and tendon disruption now become vital. Now let's have a look at the clinical features of rheumatoid arthritis. These are the early features. As you can see in the slide, the one is most commonly affecting MCPJ, that is metacarpal joint and PIP joint, along with wrist, tendon sheaths around the joint, which includes of wrist, foot, knee, or shoulder. Bilateral symmetrical polysynovitis is also the early feature. Pain, fusiform, swelling, stiffness, loss of mobility. Constitutional symptoms include LOA, MOW, malaise, and low-grade fever. Also, tenosynovitis. These are the clinical features. As you can see in the pictures, how rheumatoid arthritis attacks to the joints. As you can see, shoulder joint, hip joint, knee joint, ankle joint, wrist joint, elbow joint. The symptoms of rheumatoid arthritis include pain, inflammation, redness, and your joints will be warm to the touch. Now here comes the late features, that is destructive. These are the late features of rheumatoid arthritis. The first one is spread to other joints like wrist, ankle, knee, shoulder in order of frequency. The second, as we have seen, morning stiffness more than 30 minutes improve with activity. Activity of daily living will be affected. That is quality of life affected. As you can see, the clinical features of particular rheumatoid arthritis. It is characterized by synovitis and joint destruction. This is how you can differentiate between normal and rheumatoid arthritis. Please have a look at the picture. In the picture, you can see the normal one and rheumatoid arthritis scale. Where normal one includes synovial membrane, cartilage, and capsules. And here you can see in rheumatoid arthritis, inflamed synovial membrane, pannus, synovial major cell type, as you can see, neutrophils. Moving forward on the next slide, having a look at the clinical features of rheumatoid arthritis. After the stage shot, we'll be having more later what we can see in the deformities. Pain, deformity, instability, decreased range of motion. Joint deformity includes movement restricted and painful. Thumb can cause that deformity. Fingers can have swan neck deformity, ulnar deviation, and more. Wrist can have radial and volar displacement. Elbow can have limited extensions. Shoulder can have limited abduction. Knee joints have swollen flexion and valgus. Toes are clogged. As you can see the deformities in rheumatoid arthritis. You can have a look at the picture. Here we can see the ulnar deviation. Is that thumb? Muscle wasting. Boutonniere's swan neck deformity. Joint subluxation of metacarpal joints and wrist. Next, clinical features of rheumatoid arthritis. Here we are with physical examination of articular Z deformity, that we can see what we can see in Z deformity. Here you can see radial deviation of the wrist, ulnar deviation of the digits. In the swan neck deformity, you can see the hyperextension of PIP joint, also the flexion of DIP joint. Next is Boutonniere's deformity. Here you can have a look at the picture, which includes flexion of PIP joint and extension of DIP joint. Here comes the natural history of rheumatoid arthritis. At present, it can seem to be like this. After 5 years, if you are having rheumatoid arthritis, you can see in the picture, it can lead to this. And after 15 years, it can lead to this. It is a chronic disease, progressive damage leading to the joint deformity and disability. Extra-articular diseases include nodules, lungs, eye, vasculitis, etc. Diminished life expectancy. Now let's have a look at the diagnosis of rheumatoid arthritis, how we can diagnose the particular condition. Most clinical is bilateral symmetrical polyarthritis involving proximal joints of hands or feet, present for at least 6 weeks. It is confirmed with subcutaneous nodules or periarticular erosion on the X-ray, as you can see in the picture. Here you can see the nodules. These are periarticular erosion on the X-ray. It is a marginal erosion. And here comes the joint space narrowing, periarticular osteopenia, and here you can see the soft tissue swelling. Moving forward to the next slide, here you can see the classification, ulnar rheumatoid arthritis, classification criteria, joint involvement, 1 large joint, 2 to 10 large joints, score 1 to 3 small joint with or without involvement of large joints. You can have a look at the scores of the chart. 4 to 10 small joints with or without involvement of the large joints. Above 10 joints, at least 1 small joint. Next, we can see serology, acute phase reactant, let list. 1 test result is needed. Duration of the symptoms. Moving forward to the next slide. Here we can see the investigation part. FBC, normocyte hypochromic anemia due to abnormal erythropoiesis from chronic inflammation. WBC. Inflammatory markers include ESR, as we have discussed earlier, CRP elevated, its use as indication of disease progression, monitoring, treatment response. Rheumatoid factor include anti-LG, auto, 80% will have it. Anticyclic citrullinated peptide. This all are the investigations we have seen. Now let's have a look at the table for synovial fluid. You can have a look at the features, example, viscosity, color, and clarity. Moving forward to the next slide, investigation imaging for disease monitoring treatment response. For early stage synovitis, soft tissue swelling, periarticular osteopenia. Later stage includes destructive, that is erosion and the narrowing of joint space. The third comes the advanced stage, that is deformity. It includes articular destruction and joint deformity. Here you can see the investigations. This is how a normal hand looks like. You can have a look at rheumatoid arthritis X-ray. Here is the bone erosion, bone displacement. The progress of disease is well shown in the patient's X-ray. As you can see, figure 2. Here we can see the soft tissue swelling, panarticular osteoporosa. Ultimately, we can see that the joints are becoming unstable and deformed. Also, I wanted to let you know that X-ray hence reveals the early changes of rheumatoid arthritis with classical juxta-articular osteopenia and uniform narrowing of the distal radioulnar, radiocarpal and metacarpal joints. Also, subluxation at the first metacarpal and IP joints causes the classical hitchhiker's deformity. Moving forward onto the next slide, management. There is no cure of rheumatoid arthritis. Aim to delay the progression of the disease, alleviate symptoms, and reduce functional limitation. supportive and palliative. Medications include NSAIDs. NSAIDs include ibuprofen, indomethacin, COX-2 inhibitors like celecoxib and valdecoxib. These are helpful in reducing the inflammation and also relieves the pain. Next is analgesics. Morphine and acetaminophen are used to reduce the pain. Next comes under the management as glucocorticoids or prednisolone, prescribed in a small dose to slow joint damage caused by an inflammation. Surgery. Surgery generally improves the quality of life. Now let's have a look at the surgery which are generally seen in the cases of rheumatoid arthritis. Synovectomy. When one or two joints are affected more severely than others, this procedure is used to reduce the amount of inflammatory tissue by removing the diseased synovium or lining of the joint. It may result in less swelling and pain and the slowing or prevention of further joint damage. Next includes arthroscopic surgery. It is a thin tube with a light at the end inserted onto the joint through a small incision. It is connected to a closed circuit television and we can see the extent of the damage in the joint. Tissue samples taken, remove loose cartilage, repair tears, smooth a rough surface, or remove diseased synovial tissue. It is most commonly performed on the knees and the shoulder. Disease-modifying antirheumatic drugs. They are used with NSAIDs or prednisolone to slow joint destruction caused by rheumatoid arthritis over time. Examples are methotrexate, injectable gold, penicillamine, azathioprine, chloroquine, hydroxychloroquine, sulfasalazine, or oral gold. Medication includes biological response modifiers. These drugs directly modify the immune system by inhibiting proteins called cytokines, which contribute to inflammation. Examples for this are abatacept, etanercept, infliximab, adalimumab, and anakinra. Six include protein immunoadsorption therapy. This is not a drug but a therapy that filters the blood to remove antibodies and immune complexes that promote inflammation. Moving forward on the surgery part, it includes osteotomy, literally meaning to cut the bone. This procedure is used to increase stability by redistributing the weight on the joint. Osteotomy is not often used with rheumatoid arthritis because there are other options available besides cutting the bone. Joint replacement surgery or arthroplasty. This is the surgical reconstruction or replacement of a joint successfully used to help people who otherwise might be in a wheelchair. Joint replacement surgery involves the removal of the joints, resurfacing and relining of the ends of the bones and replacing the joints with the main component. This procedure is usually recommended for people over 50 or who have severe disease progression. Typically, a new joint will last between 20 to 30 years. Next is arthrodesis or the fusion. This procedure fuses two bones together. While it limits movement, it does not, it does decrease pain and increase the stability of the joint in the ankles, wrist, fingers, toes, and spines. Moving forward onto the treatment part, on the onset of disease, we can use NSAIDs or analgesics. Exercise in the early stage of first to 6 to 12 months. NSAIDs, analgesics, low-dose corticosteroids, disease-modifying drugs, physiotherapy, and splintage. Progressive erosive is up to 1 to 5 years. And the treatment for this is disease-modifying drugs, splintage, surgical management including synovectomy, arthroscopic surgery. Reconstructive surgery include arthrodesis, osteotomy, and arthroplasty. Now let's have a look at the complication of rheumatoid arthritis. The complications of rheumatoid arthritis includes fixed deformities, muscle weakness, infection, spinal cord compression, systemic vasculitis, and amyloidosis, that is renal failure. Thank you.